Hey everybody, I'm Dr. Heather Denniston and I am back with the Junk You Should Know show, and today we have a return guest, Reed Cooter, and let me just tell you, I don't have a lot of return guests, but I could not bring Reed back because the last show we did together, which I will post in the comments, was so crazy successful and viral that I thought, you know what, this is an incredible guest. People appreciate you, Reed, and I am pleased to have you back for a whole different subject. We're going to talk about, I'm hurt, now what do I do? Right?
Great.
Reed, thanks for joining me. Reed, you are the owner, creator, developer, launcher, worker, janitor of Phoenix Physical Therapy in Issaquah. And you are in what's the name of that building again?
Issaquah Medical Building.
Issaquah Medical Building. Cut through between the post office. That's now open again, right?
All the way to Costco now.
That's amazing.
It's an amazing road.
That's great. So that is an easy place to find. If you are looking for a physical therapist, let me tell you from personal and professional experience, Phoenix Physical Therapy and Reed and his team are incredible. So let's just get that out of the way right away. So before we go any further, I'm going to ask you a little bit about your background, but let's do just a quick thank you to our sponsor, The Change Cave. The Change Cave is a 12-module online rotating educational tool about foundational principles and wellness. It's for over 40 women who want to be inspired and want to ignite fire to their wellness aspirations. And what's awesome is it also includes newscasts and mindset seminars once a month and tons of expert presenters. And so please, if you are thinking at all about taking your next steps in wellness, be it nutrition or fitness or mindfulness, come and join us. I'm going to put the link down below so that you can find out more about it. Reed, tell me a little bit about your background. I've known you for a long time. I can tell you what kind of Chardonnay you like, but tell us a little bit about your educational background and what has brought you to the place that you are now.
Yes, so I've been a physical therapist for just over 20 years, almost 21 now. It's crazy when the time flies, right? I graduated from the University of Puget Sound and thought for sure I would come out and work with more neurologic or like patients after strokes or spinal cord injuries, and just really fell in love with orthopedics and started my first job with a clinic that was associated with the Seahawks and kind of got that high-end level athletic background, and came into Issaquah and then started working with the ProLiant Surgeons Group and started their practice back in 2001. And then 13 years later, decided to open up Phoenix. So we're almost 4, which is
awesome.
Crazy. And
that's incredible.
It is. And we've certainly developed a great team here as far as adding staff. We had a new staff member last year, which has been great, and just continue to climb and grow. So we focus on outpatient orthopedics. So post-op, also injury, preventative. We do some conditioning and training as well. So kind of seeing folks from all over the spectrum of injury.
I love that. And I know, having been in there recently, occasionally you get a pretty great professional athlete sighting. And you also you give the humor for free. So I find that when I'm in there, we're laughing our faces off a lot of the time. And it's a really awesome, enjoyable, great energy place to be. So like I said, if you are looking at all for physical therapists, please don't hesitate to connect with Reed and his team. So we're talking about today people who get hurt, and often you and I might be at a social gathering, we might be hanging out with friends, and you're about to take your first sip of an adult beverage and somebody taps you on the shoulder and says, oh, I just found out you're a physical therapist. Yeah, I've got this shoulder thing and I'm just wondering, can I talk to you about that? Or do you get that? Does that happen to you?
All the time. You try to think about what you could say that you do, that people won't ask questions, but and I think it comes with this misperception that, well, I've got some shoulder pain, what should I do to fix it? It comes with this awareness that injury isn't necessarily as complex as it is, right? Mm-hmm. So I think we're not a Google search. You can't just type in shoulder pain, what do I do? There's so many reasons why I say the shoulder might be sore, whether it's a joint problem, a tendon problem, a ligament problem, a posture problem. To get to the bottom of how to fix it, there's a pretty excessive evaluation that comes down to a differential diagnosis to see what we might do to treat those different tissues. So
yeah, that makes sense. And you mentioned Google search, and you and I have both had tons of patients saying, well, I searched it, and so I did this, this, and this, and it's not better. And you and I are like, Yep, because it wasn't properly diagnosed and the treatment wasn't targeted toward what's actually going on. And sometimes people do improve themselves at home, which is wonderful. But the problem is, you and I both know that often pain signals will drop down, but the dysfunction, the imbalance, all of that may still be there. Can you talk a little bit about why we need to investigate thoroughly what's going on so that we correct it fully?
For sure. I think, we talked a little bit last time you and I chatted that oftentimes symptoms aren't the direct tissue involved. So you might have shoulder pain, it could be coming from your neck.
Mm-hmm.
Knee pain, it could be coming from your hip. So to self treat based on symptoms is kind of a misnomer. And somebody can put on YouTube or whatever. This is what I did for my knee pain.
Geez, so sorry. Hold on one sec. I thought I turned that off. Let me go ahead and turn that off. Pause. It's not for you. It's not. It's not for you.
I'll take extra.
I'll take a message. I'll take a message.
That's good.
Go ahead. You were saying. I'm so sorry.
People put online the treatment that might have worked for knee pain. And again, there's so many different reasons someone could have knee pain that approach may be okay, and it may control your symptoms 30%, or it could, in the opposite, make you worse.
Yeah.
If you're treating something that's not meant to be treated that way. So I think, figuring out what the cause of the problem is and being able to treat it from that perspective is so important.
Yeah, I agree with you. So let's bark up that tree, if that's the right metaphor. We've a couple different categories. So let's talk first about soft tissue versus nerve stuff. How do I know if I've got some kind of injury? Is it just a muscle thing? Is it just soft tissue? Is it just inflammation, or is it a nerve issue? And how do I deal with both of those?
Sure. I think there's some different presentations for both. Nerve injuries in particular are going to present typically with some classic signs of burning, of course, numbness, tingling. The nervous system is going to give you that sort of feedback, whereas soft tissue injuries are more of that pain, stiffness, achiness upon use, and there is some, and this is where I think the important piece to having that proper evaluation is, you could have some stiffness because a nerve is injured, but the muscle system is trying to protect the nerve by creating tension. So there is so much overlap that it's difficult to say this is how you treat this and this is how you treat that.
Yeah.
But you're talking soft tissue, of course, muscles, tendons, ligaments, those sorts of things, versus true nervous pain is that electrical system of our body somehow is being involved, whether it's compression at the low back, let's say, compression in the carpal tunnel, or just mechanical deformation somewhere along the chain because of a tight posture muscle in the chest pinching the thoracic outlet, right? So the burning, numbness, tingling, those are typical red flags for the nerve pain.
Yeah, I like how you're saying that. I've got a presentation I'm doing where we're talking about wellness programming in corporations and how we have to not give a blanket wellness program, but we have to target the individual. And what you're saying reminds me of the fact that when somebody injures themselves, there isn't some global treatment that's going to work for them because there is nobody else who's exactly like them. Their anatomy, their past history, their past injuries, their stress level, their hydration, their inflammation, all of those things are going to be different. And it takes an expert like yourself to kind of unravel all that and figure out the best approach. Am I right?
We do use protocols for post-op presentation, let's say an ACL reconstruction, for example. And I use it loosely because I think what it gives us is the important piece of timelines of tissue healing. Like we know that ligament, when it's reconstructed, either using a hamstring or your patellar tendon or other choices available, we know the length of time that ligament has to heal. We know at which point we can put enough tensile force through that ligament through activity or sport to feel safe doing that. That doesn't mean that patient comes in, and I'm not going to apply the same blanket statement to somebody who prior to injury was a high-level professional athlete or was, I had a grandma who tore both of her ACLs doing a pogo stick for her grandkids. Like a different kind of, yeah. You did well.
Not something you recommend necessarily.
No. I mean, yeah. She did really well. But so you're going to approach that protocol differently because assuming the professional athlete is, say, in their 20s and 30s, that tissue quality is different than somebody who's in their sixth decade. So there's a delayed healing time as far as muscular recruitment. There may be a different awareness over pre-op status as far as how strong was the quad before surgery, what can we get back afterwards. So protocols are used, but very loosely. And I agree, it needs to be individualized for each patient that walks through the door.
Yeah, I think that's really good. One of the next buckets I find I get asked about all the time is the terms sprain and strain are loosely thrown around, and most people actually don't know the difference between the two. So what is the difference, and how does treatment vary?
So we think about sprains being ligaments, and we think of strains being muscle. So, and with that muscle, that kind of loosely ties to the tendinous junction as well. So if we're thinking about a true sprain, it applies to the joint tissue, right? So ligaments that are trying to hold the joint together. So an ankle is a great example. When you come down wrong and your foot turns inward, we have a lateral ankle sprain with that. And so ligamentous tissue, if we look at that just under, not even under a microscope, if we just look at it from the perspective of the tissue quality, it's very white, right? If we look at flank steak and that connective tissue on the backside of a flank steak, right? Very white because it doesn't have a great vascular supply. So blood flow into that tissue is going to be compromised as far as the healing time for that tissue. Muscles, on the other hand, again, the flank steak, the steak part of that, very beefy red, right? Because it's got such vascularity that the healing time takes a lot less. We can deliver our nutrients there a lot faster. It's kind of like taking a country road versus the freeway to get to the. So we think about them differently because there's a different healing time in general, but also the way the muscle or tendon responds to injury is different, based on the quality of collagen tissue and vascularity. Okay,
that's interesting. And so for you as a professional, you have different protocols that go with each of those, and different, icing, heating, taping, whatever the exercises, that it all varies depending on whether it is an actual sprain or it's more of just a strain. Is that correct? Okay.
To even complicate it a little bit more, but I think hopefully to highlight it, we look at tendon injuries. Let's say the Achilles tendon, right? There's tendinitis and then there's tendinosis.
Oh.
The difference with that is basically time and ability for tissue to heal. So tendinitis is basically acute swelling from a isolated injury, whereas tendinosis is a chronic injury to a tissue that hasn't been given the proper time to heal and now has different changes in the actual degeneration of collagen within that tissue. So you treat it very differently.
Yeah. Right? That makes sense. And this might be a good place to just talk a little bit about if you haven't sought the correct treatment and handled the injury properly, we can have adhesions set up and scar tissue. Can you talk a little bit about what happens when we see that those fibrous tissues lay over the muscle, the tendon in crisscross, and how that affects the person if they don't get the injury treated properly up front? Tell me a little bit about that.
I think there's a couple things. So if we're looking at like fascial layers of connective tissue and scar tissue, we will start to lose flexibility, right? So the layers aren't gliding on each other as they should. So you're going to, like, let's say the hamstring in particular, very densely covered with connective tissue. If those layers start to adhere together, you're not going to get the right slide when you bend forward to put your shoes on. So you're going to start to pull that hamstring and or pull the sciatic nerve along with it because we're not seeing the right motion compensate with more motion at the back, right? If we're looking at in particular in the tendon, and anytime we sprain a ligament, we're going to see a matrix of scar tissue set in. And the analogy I use with patients all the time is scar tissue is just like dropping a box of toothpicks, right? There's no organization to those tissues whatsoever. So it's a crosshatch pattern, but the ligaments need tensile force in one direction only. So let's say the ligament goes up and down. There's no need to have a fiber going sideways. We need to have all those fibers aligned back upward so that we can get the full tensile force out of that ligament or tendon. So Achilles tendon, another great example. If you want to push off and sprint, that needs to take at least 3 times your body weight to do that. So if the organization of the tissue is unorganized, there isn't that tensile force available, which is higher risk for tearing, higher risk for re-injury. And that's where we see that chronicity of tendinosis, where now the collagen tissue is degenerating instead of aligning itself and being treated well.
That makes total sense. And I think one of the biggest things that we're trying to get out of our visit together today is encouraging people that when in doubt, always be evaluated by a professional and have them help you come up with whatever treatment program is appropriate for your particular injury and combination of things going on. It's so much better safe than sorry. And again, the pain signal may come and go, but if there's been an injury, please definitely seek the expertise of somebody who does this for a living. So that's really key. Now, another one, I had a fella come in to the clinic, and he told me he'd been in a motorbike accident, and he wanted me to adjust. His leg had been injured. His knee was bothering him. He wanted me to start working on his knee and adjust his knee and stuff. And I said, well, tell me a little bit about the injury. He flew off his bike and literally landed on his bent knees at whatever mileage. And so I said, well, let's just take a look. And I literally could feel the kneecap in 3 different pieces. And so I said, we're going to need to send you for an x-ray. And he argued with me. And I said, no. And I held my ground. And sure enough, it was blasted apart into 3 pieces. How can the lay person kind of have a clue if something is fractured versus not fractured? What's your recommendation there?
Well, sometimes it's easy and sometimes it isn't, right? I think the obvious signs of fracture are deformity, right? And I think you look down at the kneecap and you see, instead of being contained in the space it's meant to be, it's kind of separated, looks bigger. I mean, there could be swelling, right? But if you feel it and you feel those divots, well, that's not right?
Yeah.
Deformity is easy. I think, when it comes to lower legs, it's a little easier sometimes than arms if there's more of those occult fractures that you don't quite see.
Yeah.
But so there's rules like for ankle fractures and like weight bearing is one of them. If you can't weight bear for more than 4 steps, that's an indication to get an x-ray. If there's tenderness down at the lower distal end of the bone where the injury happened to palpation along with ankle pain, that's an indication to have. And certain other key points too that are important. But the stress fractures are the ones that are tough because
I was just going to go there. I was just going to ask you about stress fractures because those are just so tricky.
Yep. And they present like other symptoms. Like let's say you have a femoral neck fracture, or stress fracture in a high mileage runner, right? It may present like a hip flexor, psoas strain. Well, when in reality that deep pain into the hip is something we need to look at, and there's some time sensitivity to that. In terms of there's a vascular supply going to the femoral head, and if the fracture is along that vascular supply and you don't fix it, you could lose the femoral head to avascular necrosis and have to have a hip replacement, right?
Oh my word. Okay.
Right. The again, high mileage or the springtime track athlete who hasn't really done a lot of running in the wintertime is going to start to feel shin splints when it could really be an underlying stress fracture of the tibia. So there are some things we can do in the clinic to pick those up. Vibration sense is one of the things that will make a fracture line worse. So if we do some vibration technique either with ultrasound or a tuning fork, we can kind of pick some of those subtle ones up. But again, we need to be safe and sorry. And that's not that invasive as far as easy to get, and it's not that healthy, not unhealthy to get them, right? So
exactly.
So
yeah, I think that's really good advice. And again, this comes down to, well, first of all, for larger fractures, point tenderness, swelling, there's a sense of like instability and all of those things. And what it really comes down to is, if in doubt, go get the x-ray, because the negative outcomes that can happen from an undiagnosed fracture are too much. It's too significant. It's too worrisome. So making sure that you go ahead and do that. So how do I know when I come up to you at a cocktail party, instead of tapping you on the shoulder, I should just be calling you and coming in for an appointment?
Good idea. Yeah.
Right? I know. So, but how do if I'm at home and I'll use myself as an example. I came to you not that long ago with a pretty awful ankle sprain. I could have chosen to kind of work on that at home. Is there a point where you're like, yeah, just ice it for a few days. If you can walk on it, that's fine. Or no, you need to come see me. Do you have sort of a boundary there that one crosses over that you're like, yes, you need to call me? Or is it just anytime you have an injury, just have somebody evaluate you? What are your thoughts on that?
I don't think that's a bad idea, just to make sure that and evaluate and then have another touch point to make sure you're progressing in an expected way, right? There are timelines and things like for an ankle sprain, for example, like one of the things people don't get back quickly is their ability to bring their toes up or dorsiflex, right? So that motion is important when you're walking or coming down the stairs. If you don't get that motion back in a timely manner, your ability to get it down the road gets less and less, right? There's a window of opportunity, right? So I think there's a moment for us to show you what to do and kind of give you guidelines. But I do think manual therapy is super important, right?
Yes.
Getting the fluid to get out of there, as far as mobilizing the joint to retain the normal mechanics as you're healing. Swollen, like compared to putting on a tight jacket and trying to hug somebody, right? You don't have that mobility because everything is stretched out from the swelling. So
yes.
The motion isn't a nice, proper arthrokinematic, we call it. It's more of a shear force when you're trying to do that motion with the swelling. So I think therapists and chiropractors are focusing more on those mechanics of the joint to make sure that the motions return in the right way. So you don't have long-term compensations. You
bring up a really good point here, and I didn't talk to you about mentioning this, but One of my biggest pet peeves in my chiropractic office was when I was just, working on somebody for wellness and they ended up having surgery for something unrelated to what I was working on them with. And then they came back and they said, yeah, my orthopedist said, just, you're fine. You don't need to do anything at all. And I think to myself, you just had your whole hip cut open. There are all sorts of adhesions and tissues, and you don't know the proper ranges of motion that you need to get back to. If you are having any kind of orthopedic surgery, my recommendation to you is whether your surgeon says you need it or not, you go to a qualified PT to walk you through the rehab. Because do you find this?
Yeah, it's better now. I think there are still opportunities for improvement. I think a lot of docs will say just go out and walk, you'll get better. And unless it's a traumatic injury to that hip, there's probably something that led you to degenerate the joint in the first place, whether it's bad, spinal mechanics or weak glute medius or something wore that joint down a little faster, right? Maybe it's a position. So we could address the things that got you down that road so that your recovery is even better. Look at ankle, there's a high percentage of, especially women athletes, that sprain ankles that have a weak hip abductor. So it gives you higher risk of doing that. So if we can, it's not just addressing the ankle, we address the higher chain and then we minimize your risk of re-injury.
Yeah.
So we can certainly do to set you on a better path.
I think that's true. And also if you've just been in bed or very immobilized for 6 weeks because of a hip or a knee surgery or whatever, the work that you do is going to not only get you better faster, but regain ranges of motion you didn't even know you were missing. But I also want to bring up another point, and that is near the end of my brick and mortar practice was seeing more and more doctors referring for physical therapy pre-surgery to strengthen and ready the patient for this traumatic event they were going to have called surgery. And so are you seeing that more now, that you're getting referrals in pre-surgically?
We are getting more referrals. We're also seeing some insurance companies demand that, as far as that they have to show they've failed a course of 6 months of conservative care before they'll approve the actual surgery, which is a detriment to the patient, to be fair, because we've told them over historical years, wait as long as you can. And now we're going to tell you have to wait 6 more months. So
right.
You have to find a balance there, right? But I do think, and I see a lot more people, even just 1 or 2 visits before surgery, if it's not an insurance requirement, where we're actually just doing prehab.
Yes.
Getting the system up, better in, better out. And the stronger you go into surgery, the more awareness and muscle memory you'll have coming on the other side.
Okay, can we just recap on that? You use the term prehab, which I love. That's sort of a newer term, I think, for people. So that is rehab is, after the fact, prehab is before, and then you just said better in, better out. So it's true for anything from pregnancy to, whatever. The stronger you are going into this event, the stronger you are going to be in your recovery. And so keep that in mind, folks, when, if you are scheduled for any kind of surgery or any kind of event like that, don't kind of just lay down and wait for the surgery. Do everything you can to be as strong as you can going in. Yeah?
Passive participant in this.
Yes. Yeah, good. Okay, another thing that I get is, well, let's talk about bad advice, first of all. So if I have a terrible injury and I go to and I go to a doctor who I leave feeling like, I don't know if he really examined me fully or if he got what I was saying. When do you advise patients to get a second opinion?
Well, I think, first things first, you need to be able to feel heard, right? So as long as you feel like your symptoms were attended to and you felt like they understood what you were feeling, because the reality is nobody knows your body better than you.
Yeah.
It's your system. You live with it every single day. What's normal for you may not be normal for the next patient that walks in the door. So when someone says, I can't reach over my head, but I could yesterday, or I can't reach just to shoulder height, maybe they, again, it's not based on a normative value, but it's based on their history, right?
Yes.
If you're not seeing that you're making the progress that you think you need to, or if the pain's lingering and it becomes chronic, or, you feel like there's something that's missing from that visit with the physician, a second opinion is not a bad idea.
Yeah.
I think the caution is when people try to continue to seek different opinions, trying to hear what they want to hear.
Yeah, that's such a good point.
You have to be open to the answer not being what you want it to be. But it's, have a second opinion, a second set of eyes. We do it here all the time in the clinic. If I'm looking at a patient I've seen for 3 or 4 visits, I have the same lens. And if I bring another therapist in and say, hey, what do you see? They might see something from a completely different angle that I'm like, how did I miss that? Right?
Yeah, I think that's great. That's great. And I do love that you brought up, be aware that you seeking to get the answer you want to hear, like a shorter recovery time, or whatever it is you want to hear. It may not, it may not be the answers that you're going to get. Good doctor, bad doctor. Okay, so one other thing that I run into with clients and patients is when they have a milder injury, at what point can they just sort of reduce that? You know, I think a lot about elite athletes, right? If you don't understand how to work with elite athletes, you can't take them out of play very easily. They're not, A, mentally, they're not going to, B, their coaches are going to say, forget it. So at what point, whether you're an elite athlete or not, can you say, go ahead and continue your activity at a modified or very moderate degree and see how you do? How do we litmus test whether that's appropriate?
Well, I think, again, that comes back to the type of tissue that's injured, right? So there are, like, connective tissue needs some sort of modified tissue loading to help with healing. So it's not about bed rest. We know that's not right anymore. It's not about completely scaling back to, you know, stationary bike if you're a high level athlete. We need to have some tissue load for that matrix of scar tissue to set in, for the tissues to actually respond to the healing, to make sure that we're getting it. But you also need to look at, there's tissue load and there's tissue capacity. You don't want to exceed what the tissue is able to tolerate today. A great example is Jerry Rice, after having his ACL reconstruction, did a patellar tendon graft, which they take a third of the patella out with the tendon and another piece of bone at the bottom. And he made dramatic recovery. His quads were rock solid. He had great range of motion at between 4 and 6 weeks after surgery, and went back out to play way too soon. And his first play, he jumped up to catch a pass. When he landed, he fractured the rest of his patella.
Oh, geez. I didn't know that.
It's not a great, yeah. So, I mean, then he's back out again, right? So we need to make sure that we give the timing of tissue healing the right respect, right?
Yeah.
But there is, you can't just sit and wait for the tissues to heal either. There's so many other things we can be working on, joints above and below,
yes,
right? And making sure that we have the right range within the timing that we need it. You know, again, ACLs, not to keep harboring on those folks, they used to wait for 6 weeks to send them into therapy because the fixation techniques for the ligament was like basically healing in a bone hole. Now we have great fixation techniques, and the technology has improved that we can mobilize and get that knee moving day one. So,
yeah, are those the ones that come out of surgery on the mobile machine?
They don't use those as often, but yeah, they used to use those quite a bit.
Yeah.
Injuries. That's a really great way to kind of smooth the potholes out after our cartilage injury.
Oh, yeah. That's interesting. I know there was another question, just what we were talking about.
In terms of tissue loading, I think, you know, part of that is going to help to mediate your pain response. Doing some of that motion, that tissue load, tells the body it's okay. It doesn't have to be in this spasm trying to protect the joint. When you start to move it, it goes, oh, okay, that's all right.
Yes, and it helps patient confidence as well, doesn't it? You know, you start to go, oh, okay, I can do this. I want to touch back on something you said about the joint above and below. One thing that I run into a lot with my wellness clients and as a previous chiropractor in practice was, I just had a knee surgery, so I can't go to the gym for 10 weeks. So I just want to encourage people, and please let me know if you think this is appropriate in your line of work. Guys, you can still do a bicep curl. So you still protect the time for movement of the rest of your body while respecting your joint that's healing and not doing anything silly, but making sure that you aren't abandoning all of your physical activity. Get creative, think outside the box, do things that are in other body areas, and so that you can still stay fit as you continue to heal.
Absolutely.
Agree?
Absolutely. And, you know, we have these athletes who, you know, are taken out of sport and then they kind of sit on the couch and eat potato chips. Well, you know, there's the arm. If you have knee surgery, get on that arm bike in the gym and just pound out your cardio with your upper body, right?
Yes.
The seated machines where you're well protected from the you know, hips down, bicep curls in the machine, rowing in the machine, lat pulls, all of those things are fair game. You know, and if you're protecting a shoulder, get on the stationary bike.
Yeah.
Because you can't do that as long as you're not, you know, loopy on pain medication and going to fall off. But there's a ton of things you can do to maintain cardio, strength, and overall health.
Well, and for sure, and just the movement, the exercise itself is going to nurture great healing physiology in your body and good circulation, and so it's only going to help you to recover faster. So the whole concept of fear avoidance, where people are like, oh, I can't do anything for 10 weeks. That's what the doc said. No, the doc said you couldn't do that joint for 8 to 10 weeks or whatever it is. But don't forget, you got to keep the rest of you in shape. Home care. What kinds of things, if I've just injured myself on a Friday afternoon, I can't get into you till Monday or Tuesday. What are some of your go-to recommendations?
Well, there's the classic rice we've turned into price with 2Rs. So there's protection, right? If it's a ligament injury, you want to kind of protect that joint. The 2Rs are relative rest. And again, we kind of touched on that in that last topic there. Right? It's not about sit on the couch, put your leg up anymore. It's about, well, what can I do to protect this, but have still some relative rest from anything that might injure me more. And then there's the ice, compression, and elevation to finish out the anagram. So, I think that still applies when you're trying to look at acute injuries for sure. I think it depends on if it's more chronic injury. We might change that mindset a little bit differently. And again, I think that's where you need to come in and be evaluated to change the path. I mean, you're getting what you're getting because that's what you're designed to get when it's chronic pain. But
so the compression, are you just suggesting either some kind of compression thing that you get at the drugstore, or an ACE bandage or something along those lines?
It can be as easy as an ankle sleeve, a knee sleeve. If it's the upper arm, you can just use an ACE wrap if you need to contain swelling within a joint. The hand gets a little more difficult as far as ways to do that. Obviously, the shoulder is a difficult one, but those extremity joints are easy to use compression with a simple ACE wrap. Not too tight.
For sure. Not too tight. And then icing, 20, 30 minutes on?
Yeah, I like the 20-minute max. There's the hunting response after 20 minutes where our body feels like it's getting too cold, and we'll send more blood that way to try to warm that extremity back up. So now we can make effective ice essentially. So, and I think, most times we go through a cold, burning, aching numbness settings with cold. And it's, the burning and aching people don't like, but you've got to get to that numbness point. And so with a general ice pack, usually 20 minutes, ice massage 7 to 10, depending on the subcutaneous tissue.
That's
ice
good.
Shorter, for sure.
Yeah. And just make sure that you let those tissues completely rewarm before you think about applying ice again. So I think that's really good. Good. Did we miss anything? I think we covered a lot of ground, Reed.
A lot of ground. There's also the topic of ice and heat.
Oh, right? Yeah.
When to use ice?
People are always asking that. What's your recommendation?
Well, that's interesting because there's some new studies. Even that the gentleman who came up with the initial rice principle has changed his mind on the ice part. A lot of the studies are being done on more performance. So they're looking at normal everyday training using ice, and then what's the performance after that versus acute injury. So I think we're kind of muddying the water a little bit with the conversation. Because I think it's a really good place in injury. It may not as far as recovery after a normal workout when you're looking to perform or gain strength or build bulk. But I think for an injured joint, ice is still pretty effective. Chronically, I do tend to turn to heat, or if we go back to the tendonitis versus tendinosis, osis responds to heat, itis responds to ice. So you treat those two a little bit differently. Otherwise, I still think ice has a really good play in somebody who's acutely showing up in your office with a swollen joint.
What did the study say about ice after, as almost like a preventative measure after, competition or whatever? Was it just saying that what was the reasoning behind?
Well, it looked at, so there were two studies, and I'm going to butcher this a little bit and not be completely, I'll be as accurate as I can recall. But so they had two groups where they each did a normal training workout, and then one group got ice, one group got heat, say like to the quads or maybe an ice bath or just a sauna, right?
Okay.
And so then they looked at performance the next day as far as like a time trial of a run or that sort. And so the people who did heat after normal training did better. They fared better. So I think our inflammatory response is very good. And in training, it's doing what it should do. In an injury, it's overzealous. I mean, you get way too much. Things are clogged. It's kind of like the traffic on-ramp lights, right? You don't want everybody to get on the freeway at the same time. You want to titrate some of that fluid so that it can do its job and not just be completely stuck and not be able to go anywhere. And
I think that's very true. And I also think we haven't even touched on the subject of the fact that about 70-80% of the people coming in are in a pro-inflammatory state because of diet and chemical exposure and all of that stuff. So I actually really like those recommendations. It's funny, we were ready to go to fisticuffs over the ice heat thing because chiropractors tend to lean a little heavier on the ice. And I have found in my history that physical therapists lean a little more to jumping over to heat more quickly. I love exactly what you said, and I'm in total agreement with that. I think that's a wonderful recommendation. So yay, we're still friends.
I like it. To your talk last week in the illness and wellness circles, right? And I think where are you on that spectrum? And that changes the way you treat somebody.
Yes, yes. If you are, that's absolutely right. Thanks for a shout out for last week's show. I appreciate that. That's so true. A lot of people think just no signs or symptoms, I'm well, and not true. So we have to evaluate a lot of other factors to determine relative wellness. So I think that's key. Thank you for sharing that. Well, listen, guys, we are here every Friday on the Junk You Should Know show. I know for a fact I'm going to ask Reed to come back again. In fact, we may just go on the road, I think. City to city, we'll find stuff to talk about. And so that could be really fun. But I thank you for your time. I know you are exceptionally busy, and if you at all are, again, looking for some evaluation of an injury that you might have, Reed at Phoenix Physical Therapy is amazing. So please do go and check him out and his colleagues who are there as well. And so Reed, thanks so much. I really appreciate your time. And we'll see you again. And everybody who's watching live and in replay, thanks for being here. Remember, we live on forever on the Well Fit and Fed channel on YouTube. So do check us out there as well. All right. Goodbye, everybody.